Hello, my name is John Short. Today we're going to be going over chest and abdominal trauma. This is chapter 31 of your emergency care book. We'll be going over anatomy and physiology of the chest and abdomen, chest injuries, and abdominal injuries. So anatomy and physiology of the chest cavity that extends from the collarbones to the diaphragm. A lot of people call this the box. So it's dynamic because it depends on the respiratory cycle. It is packed with organs, major blood vessels, and lung tissue. So when we have trauma, blunt or penetrating to the chest, there are a lot of concerns. So the organs are well protected. It's 12 sets of ribs, the sternum, the thoracic spine vertebrae, and the scapula that are kind of protecting those organs within the chest cavity. Other physiologic functions of the chest. Obviously, the heart's beating to provide blood flow. The large blood vessels enter and exit the heart to bring blood into the heart and then out to the body. And then the lungs there for respiratory function. There's a little diagram of the things that are within the box. There's the diaphragm toward the bottom of the screen. You can see where your collarbones are at. It's kind of a poor example. The lungs take up more space than what you see right there. Mechanism of breathing. I know we've gone over this a few times so far in class. So we have the chest wall, diaphragm, and lungs that all work together. There's a change in pressure within the chest cavity that causes air to be moved in and out. So inhalation is an active process. Is where we're contracting that diaphragm, creating negative pressure to pull air into the lungs. And then exhalation, which is a passive process, that's that diaphragm relaxing and allowing air to escape. So continuing the anatomy and physiology of the abdomen, the superior border is the diaphragm. So the top part of the border of your abdomen is your diaphragm. There are abdominal organs that extend to the lower regions of the pelvis. Described in context of location relative to our four abdominal quadrants, so right and left upper and right and left lower quadrants. So our solid organs, we have our spleen, liver, pancreas, and kidneys. Hollow organs, we have stomach, gallbladder, duodenum, large intestine, small intestine, and bladder. A trauma assessment and care takes into consideration placement and function of abdominal organs. So, when we talk about like the liver, for example, liver, spleen, pancreas, those are all organs that can bleed pretty profusely in blunt or penetrating trauma. So differentiating between hollow and solid organs, hollow organs tolerate trauma pretty well. Solid organs do not. They're, obviously they're solid. So even like blunt trauma can create ruptures, lacerations, and things to those solid organs. Physiology of abdominal organs is dependent on the individual function. So obviously each organ's got its own function within the body. The abdominal cavity is dynamic depending on the location of the diaphragm. So, when we inhale and exhale, those organs' location can change a little bit. There is always a large volume of blood in the abdomen. When we talk about the kidneys, the liver, the spleen, all the intestines, and then obviously the aorta and vena cava going through the abdomen, that's a large volume of blood that's consistently in the abdomen. So we'll just have a little bit of discussion here on different things that could cause issues with the chest and abdomen. So disruption of breathing. My first thought is something like a high cervical fracture that's causing paralysis to the muscles, including the diaphragm. Obviously, penetrating and blunt trauma to the chest can cause some issues with your breathing. Rib fractures, especially if you have two or more ribs broken in two or more places and you have like a flail segment or a pneumothorax, something like that could cause a disruption of breathing. Hemorrhage and shock. Obviously, like we talked about in the last slide, there's a lot of blood within your abdominal cavity. Penetrating and blunt trauma can cause you to bleed a whole lot into your abdomen. And if you think about how pliable your abdominal wall is, I mean, you've got your entire belly that can be filled with blood. It can hold probably twice what your body's volume is. So if we have a patient that's bleeding and, for example, a paramedic dumps a bunch of IV fluid into this patient, they can hold all 5 liters of their own blood and 3 or 4 liters of saline in their abdominal cavity. Disruption of organ function. So something like somebody bleeding heavily causing a low blood pressure. You have to have a certain pressure in order to perfuse your organs. So if we have somebody that's bleeding and we haven't stopped it, we can have a potential disruption of organ function. And then infection. So any type of penetrating trauma has an ability to become infected. So chest injuries, we have blunt and penetrating trauma. So blunt trauma can fracture the ribs, sternum, and the rib cartilage or the costal cartilages. Penetrating trauma can be anything you can think of: bullets, knives, metal, glass, steel rods, pipes, anything you can think of. Obviously, that can cause damage to the internal organs or impair respiration and ventilation. Compression and shearing injuries. So this can occur when severe blunt trauma causes the chest to rapidly compress. So something like an understrain driver that hits the steering wheel and causes a lot of very sudden compression to the chest wall. That can damage the big vessels, the aorta and the vena cava. Chest injuries are classified as either open or closed, and that's exactly what it sounds like. A closed injury does not have any pathway to the outside world, and an open injury does. Rib fractures, those are normally very painful, not normally life-threatening, can make breathing difficult, mostly due to their pain and they don't want to take a big deep breath. If it is a very clean fracture that is all the way through the bone and everything, and it's displaced, it can lacerate blood vessels or lung tissue. Flail chest, that's what I was talking about earlier. That's where a fracture of 2 or more consecutive ribs in 2 or more places happens. That leaves a portion of the chest wall unstable. So that's where we see something called paradoxical motion. So that flail segment is moving opposite. So when we take a breath in and our chest is expanding, that section of your chest wall is going to move in due to the change in pressure, and it's not connected to the rest of the tissue. So here's an example of the flail chest injury. You can see there's 4 or 5 fractured ribs there in more places than one. And that chest wall that's expanding is all expanding except the flail segment. Another diagram of paradoxical motion. So patient assessment, rib fracture, we're going to consider the mechanism of injury. The pain at the site of the injury that increases with breathing is a big one. Tenderness to the area, there could be redness, swelling, bruising. They could become short of breath, hypoxic, or even into respiratory failure. The cell splinting, a lot of times they're either just holding on to that section or, like we talked about, intentionally not breathing very deep due to the pain. Flail chest, the mechanism of injury has to be capable of causing the injury. They will have difficulty breathing. There will be pain at the injury site, likely signs of shock and hypoxia. A mechanism large enough to cause this kind of injury is going to cause those signs. And then obviously we'll see that paradoxical movement with the chest wall contraction. So for rib fractures, consider the need for ALS. They are typically stable patients, but like we talked about, the pain management is really what they need. So allow the patient to remain in a position of comfort as long as it's safe for the patient. Treat hypoxia and allow the patient to hold a pillow or a cushion against their chest if that helps. So flail chest, we're going to do a primary assessment for life threats and address any of those. Administer oxygen. If they're breathing inadequately, we can assist ventilation. and then we'll follow our protocols using non-invasive positive pressure ventilations like CPAP. Request ALS for pain management. This patient may also need airway management. Monitor the patient carefully, watch the respiratory rate and depth, and don't restrict the chest wall movement. When it comes to penetrating chest injuries, it's difficult to tell what is injured from an entrance wound. We see where the penetrating trauma is. We don't always know the trajectory or the depth. So especially penetrating chest trauma, assume all wounds are life-threatening. An open wound allows air into the chest. That causes a pneumothorax at some point. We need to cover that with like an occlusive dressing, like a chest seal. So try to determine the description of the object that penetrated. If there's more than one penetrating wound, or if there's one, look for others. Where something entered, a lot of times it exits. So we need to be looking trauma naked, get the patient undressed so that we can evaluate their entire body and make sure that it didn't go in somewhere and we're missing an exit wound. We need to visualize the entire chest, but we need to visualize the entire patient. Listen to lung sounds. If there's no lung sounds or very diminished lung sounds on one side where it's clear in the other, that could identify a pneumothorax or hemothorax. So air in the chest cavity or blood in the chest cavity that's causing issues with that lung. Lung damage signs and symptoms: difficulty breathing. Talked about absent or unequal lung sounds. Hemoptysis, which is just they're coughing up blood, and hypoxia. Other signs and symptoms: shock. So this patient, especially with that pneumothorax, when it becomes a tension pneumothorax, what's happening is that lung tissue is collapsing and it's causing some pressure changes within the chest cavity, which presses against the vena cava, which is overall going to lower our blood pressure, and our body's going to try to compensate. So we'll see tachycardia because the heart rate will try to compensate for that loss of pressure. They will start breathing fast, so tachypnea. Pale skin is another sign of shock, low blood pressure. A sucking chest wound, that's just where air is drawn in through that penetrating trauma, that hole in their chest wall. It may make a sucking sound. There may be some little air bubbles as the patient's breathing in and out. On these calls, it may be known that it's a stabbing or a GSW, so we want to make sure that the scene is safe. So a lot of protocols will call for you to have the scene secured by law enforcement prior to your entry. Consider ALS. I would definitely do that. We're able to, intubate the patient if needed with paralytic drugs, narcotic drugs, and all that. In the meantime, maintain an open airway, seal the wound by applying an occlusive dressing. Allow the patient to remain in a position of comfort if possible. Administer oxygen, treat for shock, which is really keep them warm, and prepare for immediate transport. So occlusive dressings seal up the wound to stop movement of air. We don't really do the flutter valve thing anymore, so we're not going to go over that. So does the patient's chest injury need to be treated during the primary assessment? Yes. Yes, it does. That is a life-threatening or potentially life-threatening issue. So if there's penetrating trauma, we're going to put an occlusive dressing on that during the primary assessment when we find that, during our HABC or whatever mnemonic you want to remember during your primary assessment. Does the open chest injury require an occlusive dressing? That's another yes. If there is an open chest wall injury, we need to make sure that that's closed with an occlusive dressing so that they're not pulling air in through that hole. And does the patient's injury necessitate immediate transport to a trauma center? Yes, also yes. So injuries within the chest cavity, we have a pneumothorax and a tension pneumothorax. So pneumothorax can occur spontaneously. It does not have to be associated with a traumatic injury, but it oftentimes is. A tension pneumothorax is a pneumothorax that's grown to the point where it's causing those pressure changes and causing the patient to go into a shock state. A hemothorax is blood in the chest cavity, and a hemopneumothorax is blood and air in the chest cavity. Traumatic asphyxia is just where the thorax is being compressed, so the chest cavity is being compressed, causing us to not be able to take a breath in and out. Cardiac tamponade is fluid in the pericardial sac around the heart that's causing compression on the heart itself. And then an aortic injury. You can have ruptures and tears of your aorta, especially in blunt and penetrating trauma. That's going to bleed a lot. There's a lot of pressure. Your aorta, right where it comes out of your heart, is the highest point of pressure in your body. So depending on where that's at in your aorta, you could bleed out within seconds. All right, we kind of got ahead of ourselves a little bit. We'll go over it again. Pneumothorax is when air accumulates in that chest cavity, and then a tension is where that pressure from the air in the chest cavity puts pressure on the heart and vena cava, causing the blood pressure changes. So air can enter through the chest cavity, through that puncture in the chest wall, and here you're seeing that lung collapse because the air is being pulled in with that pressure change, and the lung is collapsing, and eventually, like we said, it'll cause pressure on your heart and vena cava. These patients typically have diminished or absent lung sounds on the affected side. Their jugular veins may be distended because it's having a hard time getting the blood back down in the body due to the change of pressure. And when that lung starts to collapse and everything kind of moves to one side, your trachea may end up kind of shifting to the opposite side of where the injury is. So a hemothorax is where the chest cavity fills with blood. A hemopneumo fills with both blood and air. So here's a little diagram of the three different pneumothorax, hemothorax, and hemopneumothorax. Traumatic asphyxia is a sudden compression of the chest. Your neck and face can become a darker color than the rest of your body, and may cause some bulging eyes, distended neck veins, broken blood vessels in the face. This is like, have an entrapment in a vehicle or heavy machinery, that kind of thing. Cardiac tamponade can be direct injury to the heart that causes blood flow into the pericardial sac around the heart. That pericardium is a very tough, fibrous sac that doesn't really leak unless it itself is injured, but it isn't easily injured. So that causes increased pressure on the heart. So the chambers can't fill. You're going to have a really pretty sudden decrease in blood pressure. So the blood backs up into veins because we can't get it anywhere else because the heart's not pumping adequately. So we're going to get those distended neck veins. The patient's going to end up in shock. And a narrowed pulse pressure is just where, your blood pressure was 120/80 and it starts to change to 110/90, and it gets the top and bottom numbers of your blood pressure, your diastolic and systolic, are going to get much closer together. An aortic injury, the aorta is the largest artery in your body. Penetrating trauma can cause direct damage. Blunt trauma can sever or tear the aorta. Both those are really bad. So an aortic dissection, that's when the inner layer of your aorta begins to tear. The blood flows between the layers of the aortic wall. That's normally a very, very fast way to die. An aneurysm, it's like a balloon-like protrusion of your aorta, and rupture can lead to the death. So an aortic injury, the patient will typically complain of pain in their chest, abdomen, or their back. A lot of times, even with the aortic dissection and aneurysm, if it's not a large, severe bleed, they'll be complaining of chest pain that kind of radiates toward their back. They'll likely exhibit signs of shock, so pale, cool, sweaty skin, low blood pressure. Depending on where the aortic injury is, there could be a difference in the pulse or blood pressure between the right and left arms, or differences in the pulses between the arms and legs or the legs by themselves. It just depends on where that injury is in the aorta. Commotio cordis is a pretty uncommon condition. Trauma to the chest when the halt is in a vulnerable state. There's a certain point in cardiac action potential where if it is struck hard enough at that time, the patient will go into VFib. So that's just a shockable rhythm. The patient's it's in a cardiac arrest. So we're going to treat it like anything else. We're going to do CPR and defibrillate with the AED when it says a shock is advised. All right, so patient assessment for pneumothorax. We can assess respiratory difficulty, see if there's uneven chest wall movement or a reduction or absence of breath sounds on the affected side. Tension pneumothorax, increased respiratory difficulty and signs of hypoxia will be present. Eventually they will be in shock. Distended neck veins or jugular vein distension, tracheal deviation, those two are pretty late signs. You're not going to see those very quickly in a patient that has a tension pneumothorax. Hemothorax is the same thing, same signs as a pneumothorax, except they'll often cough up some kind of frothy red blood. Traumatic asphyxia, we can see distended neck veins. The head, neck, and shoulders may appear cyanotic, so blue or purple. Bloodshot, bulging eyes, swollen and blue tongue and lips, and then chest deformity or tenderness. So cardiac tamponade, we can see distended neck veins, a very weak pulse because we have a low blood pressure, and then a steadily decreasing pulse pressure. Aortic injury or dissection, those patients will typically have a tearing chest pain that radiates to the back. Could have some differences between blood pressures or pulses. Sometimes there will be a mass that you can palpate kind of in their epigastric region. It's not always present, and then cardiac arrest is likely. So for a pneumothorax or tension pneumothorax, we need to contact ALS, seal any open chest wounds, manage the patient's airway. So if their airway becomes compromised, if that's an MPA, OPA, I-gel, wherever you need to go with that. Administer oxygen to treat hypoxia and allow the patient to remain in a position of comfort. There's some other injuries that can happen within the chest cavity. We maintain an open airway, be ready to apply suction, oxygen, follow your protocols for the type of dressing that may need to be used. Care for shock. So at the EMT level, that's hypothermia prevention. So keeping them warm, transport as soon as possible, and consider ALS intercept. So abdominal injuries, same type of thing. It can be open or closed. Internal bleeding can be severe if the organs or blood vessels are ruptured or damaged. Evisceration can occur. That's when the organs are protruding through the wound opening. I think we're coming up on a picture of that. Yeah. So this is an abdominal evisceration from a stab wound. Blunt trauma to solid organs can cause life-threatening blood loss. It's a little more rare for there to be blunt trauma that causes significant blood loss in hollow organs, but it is possible. Injury to the diaphragm that can cause detachment, allowing abdominal contents to enter the thoracic cavity. So if that diaphragm is ruptured or lacerated somehow, your intestines, whatever abdominal contents can go into the thoracic cavity and create some problems with respirations. If the hollow organs are injured, they can spill the contents of those into the abdominal cavity. That can cause some pretty rough pain and infection down the road. A lot of times there's pain immediately that can be more mild, and it rapidly becomes more intolerable. Cramping, nausea, weakness, thirst, obvious lacerations and puncture wounds to the abdomen. Lacerations and punctures to the pelvis and middle and lower back. So when we think about like our kidneys are in what's called the retroperitoneal space, that's the space kind of behind our abdominal contents, kind of kept separated. Indications of blunt trauma, indications of developing shock, those are other things to be assessing in your patient. Coughing up or vomiting blood, a rigid or tender abdomen. So if we're doing an assessment and we go down to palpate the abdomen, we can feel if it's very firm or rigid. If it's hot, like more warm than the rest of the body, that could indicate that there's some blood loss in there. That will be very tender. If the patient's intentionally trying to lie very still to avoid pain. So the path of the bullet. Patient with a gunshot wound to lower ribs and same level in the back should be treated for both a chest wound and an abdominal wound. Bullets do not often take straight paths. They can be deflected by bones, trajectory, depending on the type of round that's being used. We have no idea of knowing. So for both closed and open abdominal injuries, we need to try to stay alert for vomiting and keep the airway open. So when we talk about a position of comfort, that's great. They also need to be in a position to where if they have to vomit, that they can do it without causing airway compromise. So you can place the patient on their back with their legs flexed to the knees to kind of reduce the tension on the abdominal muscles, as long as there's not a big risk of them vomiting while they're laying flat on their back and they can't clear their airway by themselves. Administer supplemental oxygen, treat for shock, so keep them warm. Don't give anything to them by mouth. We're going to continuously monitor their vital signs and transport as quickly as we can. Some additional steps for open abdominal injuries. Control external bleeding and dress the wounds. So we don't want to touch or replace any eviscerated organs. We need to try to apply a sterile dressing that's moistened with sterile saline over the wound site. We don't want to try to put any dry dressing on there. It could get could kind of adhere to the whatever organ is protruding from the wound. And that can cause problems for the hospital when they remove the dressing to try to restore that organ. For large evisceration, you can maintain warmth by placing layers of bulky dressing over the occlusive dressing that we're going to make. And then obviously we're going to keep the entire patient warm. Don't remove any impaled objects, no matter where it's at in the body. If it's causing an immediate airway compromise, we can remove it at that point, but otherwise we're not going to remove an impaled object. No, we're just going to stabilize it with bulky dressings, bandaged in place, and try to leave the patient's legs in the position found to avoid any extra muscular movement that could move that impaled object. So an open chest or abdominal wound is considered to be one that penetrates not only the skin, but also the chest or abdominal wall to expose internal organs. Open chest and abdominal wounds are life-threatening. For both open and closed injuries, we need to take standard precautions, so gloves. Note the mechanism of injury, protect the patient's airway and breathing, treat for shock and transport. We know we've discussed it in the past, but trauma patients need trauma surgeons, not EMTs and paramedics, so we need to try and limit our scene time and initiate transport very quickly. If there are signs of hypoxia or the patient's vital signs indicate or suggest that the patient is in shock, we need to administer oxygen. A flail chest is characterized by that paradoxical motion. If the patient is unable to adequately breathe, we need to assist their ventilations. We need to seal any penetrating chest wounds with an occlusive dressing, monitor the patient for changes, and be prepared to manually relieve any pressure in the chest. That's something we didn't really go over. So if the patient has a large buildup of air within that chest cavity and they start having some problems, we can temporarily remove that dressing to allow air to escape that penetrating hole, but it's not something that we do often now. It's kind of an older train of thought. Closed chest wounds are sometimes difficult to distinguish or may occur together. So we could have, bruising to the lungs along with a penetrating trauma. So assess the patient, including breath sounds, maintain ventilation, oxygenation, and perfusion. A patient who collapses in cardiac arrest after a force is applied to the center of the chest should receive CPR and defibrillation just like any other patient in cardiac arrest. If a patient develops signs of a tension pneumothorax, we need to try and get an ALS intercept unless we're just extremely close to a facility that can treat it, and it would be faster to go to the facility than it would to intercept. When solid abdominal injuries, organs are injured, there are life-threatening amounts of blood loss that can occur. When hollow abdominal organs are injured, their contents can spill into the abdominal cavity. That's going to cause irritation and peritonitis. So remember, blunt trauma, penetrating trauma, and compression, those are mechanisms that can injure the chest and abdomen. Open or closed pertains to the integrity of the chest or abdominal wall after injury. So an open injury has a pathway to the outside world, and a closed one does not. We'll seal any open chest wounds to prevent air from entering the chest cavity. Closed chest and abdominal wounds bear a high risk for underlying organ system damage and internal bleeding. So we kind of use the mechanism of injury, but mostly the patient assessment to recognize the signs and symptoms of shock. The mechanism of injury is just something to give you an index of suspicion. Things like a head-on or a T-bone collision at high speeds. I'm already thinking this patient could be badly injured, but my assessment's going to tell me if my patient's badly injured. That's just to give you an index of suspicion. It's not an assessment tool. So EMT should learn signs and symptoms and treatment procedures for specific chest and abdominal injuries, which we'll go over some of those treatments, well, all of those treatments in class. So questions to consider: is the patient's breathing adequate, inadequate, or absent? Obviously, if it's inadequate or absent, we're going to assist ventilations. Is the patient displaying signs of shocks or pale, cool, sweaty skin, hypotension or low blood pressure? Some other things are tachycardia, so a fast heart rate, and then tachypnea or breathing quickly. Is there an open wound in the chest that needs to be sealed? So is the patient displaying signs of a tension pneumothorax? Shock will be associated with that tension pneumothorax. So a low blood pressure or hypotension, tachycardia or fast heart rate, tachypnea, which is just breathing fast. And then the later signs being jugular vein distension and tracheal deviation. Is there an open wound in the abdomen that needs to be dressed and covered? Like we talked about with an eviscerated organ, we're just going to use a sterile dressing that we moisten with a sterile saline. All right, we'll go over a couple critical thinking questions. So you are caring for a patient who was shot in the chest with a nail gun. So you apply an occlusive dressing around the wound. The patient is suddenly deteriorating. He's having extreme difficulty breathing and his color has worsened. So some of the thoughts that we may have with this one, that patient could have developed a tension pneumothorax. So as far as treatment of that, that's going to be ALS interventions that need to happen. So depending on your proximity to the hospital, if it's faster to go directly to the hospital, or if it's faster to get a helicopter involved, or or intercept with the ALS ambulance. All right, so breath sounds have become almost totally absent on the side with the impaled nail. So what complication might you suspect is causing his condition to worsen? We kind of already talked about that with the tension pneumothorax. So how can it be corrected? This is a case where you could remove the occlusive dressing or just peel it back to expose that wound and allow some of that air to escape. If that air is causing more tension in there and we can allow it to escape just during 1 or 2 respiratory cycles, we're not going to take it completely off and leave it off, just enough to relieve some of that tension and put it back on to avoid more air coming in through the wound in the chest. All right, so that's it for the chapter 31. And we'll do all the skills and stuff in class.
Ooh.